at the COMAI meeting, we have talked about the primary refractory young patients. This is a difficult clinical situation. So we have reported a case of a 46-year-old lady. She was treated with VRD as induction regimen and didn't get any response. And the question is, do you switch the treatments before autograft transplant? Do you do a salvage therapy? Do you do autograft transplant directly? And so all this question came from this clinical case. So basically what we observed, so first the definition of the primary refractory young patient is patient who did not achieve at least a partial remission after an induction regimen. So what we can observe is with newer regimens, of course, it's less frequent. So we've taken different clinical trials over the years, and we saw that for the VAD induction, for example, in the past, 48% of the patients didn't achieve a partial remission before autograft transplant. So 48 of them were actually primary refractory, and this drops as the induction regimens improve, and it's about 5%, 6 for RD and 4% for KRD who didn't achieve a partial remission. So we are talking now about a population of 5% of the transplant eligible patients who won't have a good response to an induction regimen, which is still a significant number of situations that we can see in clinic. So their prognosis, of course, is not good. We can see a difference between the patients who are in stable disease as compared to the patient in progressive disease during this induction regimens, and of course the ones who are progressing under the induction regimens have a worse outcome as compared to the one in stable diseases. So the question is, do you do a salvage therapy? We know that autograft transplantation is a good regimen in this a good treatment in this situation. On some retrospective cohort, we can see that about 50% of the patients have a response after autograft transplantation, and 25% of them have a complete remission after autograft transplantation, even though they were primary refractory to the induction regimens. But should we improve this response before autograft transplantation? Actually, we don't have evidence so far. We have a retrospective study from the International Blood and Bone Transplantation, where they took about 600 patients. Some didn't receive salvage therapy before going to autograft, and some received it, and they had a very similar outcome. So in terms of PFS and in terms of OS. So we don't see a clear benefit, and we don't have evidence to say that we should salvage therapy in that situation, or we should directly go to autograft transplantation. The question is still open. So in kind of conclusion of these observations, we think that it's representing about 5% of the transplant eligible patients now with newer regimens. These patients should be considered as high-risk population, of course, and we see that their outcome is adverse, and we should likely come up with new strategies. And of course, there is very likely a place for the new therapies, such as the immunotherapies in this context, like CAR T cells, bispecific antibodies, and hopefully we'll have strategies in clinical trials that will help managing these patients in the future.